Hi, this is a recording of a talk that I did called Looking Beyond T2 Brightness, and this was about cartilage lesions and mainly central cartilage lesions. Now, if you look at chondrogenic tumors in the fifth WHO edition, you get all of these different entities, but typically the benign lesions that we see are enchondroma, osteochondroma, chondroblastoma, and chondromyxoid fibroma. And then the central ACT or chondrosarcoma grade 1, which is an in-between tumor. And then you have the malignant central chondrosarcomas grades 2 and 3. We've already discussed these in different cases at bstneoplasms.com. Chondroblastoma is a benign aggressive lesion. So you have this typical epiphyseal osteolytic lesion with a sclerotic rim, extensive marrow edema, often T2 dark, sometimes with fluid levels, and you have to biopsy these lesions. Chondromyxoid fibromas, and I did this as case 29, is typically a juxtamedullary or cortical lesion. Again, benign aggressive, so lots of marrow edema. You see a sclerotic rim on the radiograph as you do here. And again, these need to be biopsied. There's no way out. Osteochondromas are easier to diagnose. They typically have marrow contiguity. The cartilage cap is seen very well here. And these radiographs, there is no issue as far as the diagnosis and the biologic behavior are concerned. Now, if you have a cartilage cap greater than 2 centimeters or change on follow-up or marked irregularity, you may consider malignant transformation, but then you require to do a biopsy. So here is a rings and arcs appearance, aggressive lesion here. You see a cartilage cap that is definitely greater than 2 centimeters. And this is actually an osteochondroma which underwent chondrosarcomatous transformation and presented directly as chondrosarcoma. Now, these are not the focus of this lecture. The whole idea is to try and see how we label lesions as enchondroma, atypical cartilaginous tumor or chondrosarcoma grade 1, and then chondrosarcoma grades 2 and 3. And to do that, we need to know what cartilage looks like. So, cartilage can have a cloudy matrix or a rings and arcs appearance on radiographs, as you can see here. On MR, they would be lobulated, septate, T2 bright, and you need a true T2, not fat sat, not a stir, etc. And you get this classic appearance of cartilage. On contrast, it looks like a liver hemangioma. You see this nodular peripheral and the nodular central enhancement. And if you're doing a dynamic, you'll actually see the enhancement increasing in this phalangeal enchondroma. So here you can see the rings and arcs on the radiograph. You know there's an osteochondroma here, which has then undergone malignant transformation. So you have a lobulated septate, T2 bright appearance, but the cartilage cap is clearly about 3.5 centimeters. But nevertheless, it's about diagnosing cartilage. That's your typical cartilage appearance on X-ray and on MR. So to understand this whole concept of enchondroma, ACT, chondrosarcoma, let's look at this 34-year-old who came with pain in the right shoulder. He was doing an exuberant overhead set. This was what was found on the X-rays, and this was found on the MR. The supraspinatus was basically normal. There was nothing else, no labral tear, etc. Now, this is, in a way, a reasonably glaring lesion that you would spend a little time over. The PET-CT showed an SUV max of 3.2. So the findings are 5 centimeter long, entrapped fat, no endostal scalloping, no extraosseous extension, no marrow edema. And then he had no symptoms once the gym injury-related pain subsided. And so my question to you would be, what do you think it is? And that's where we come to the crux of the matter and how to differentiate each of these. Location matters. The vast majority of phalangeal cartilage tumors are called enchondromas, and I discussed this in detail in case 26. You kind of blindly, you can say that these are enchondromas. Similarly, all flat bone lesions, so osteolytic lesions, sclerotic rim here, but not laterally. It's a cartilage lesion. You see the chondroid matrix on CT, and we had biopsied this as well. But even if it's benign on histology, or it shows low-grade cartilage, because it's in the flat pelvic bones, you don't call it atypical cartilaginous tumor. It is called a grade 1 chondrosarcoma. So in the ribs, sternum, pelvis, proximal femur, everything becomes a grade 1 chondrosarcoma. So in the long bones, it's difficult to differentiate enchondroma from ACT, and many institutes don't even try. So your only focus really is to differentiate enchondroma ACT from grade 2, grade 3 chondrosarcoma. So now let's look at this 47-year-old who's got some expansion of bone, thickening of the cortex, cartilage matrix here, but there's a cortical break and extraosseous soft tissue. So when you see a greater than 4 centimeter lesion, bone expansion, cortical break, generalized endosteal scalloping, growth in 1 year, or it becomes painful without an obvious fracture, then you would consider this lesion to be a grade 2, grade 3 chondrosarcoma. But less than 4, no cortical break, no extraosseous soft tissue, asymptomatic, entrapped fat on T1, regression or stability on follow-up, and endosteal scalloping less than 2/3 of the circumference, then you would say that this is enchondroma ACT. So our patient, 2019 to 2023, no change. He was a little obsessive, so would keep coming for MRs. You can see the entrapped fat here. No change over 4 years, and we've done one more in 2024, which again does not show change. So though it's 5 centimeters, though there's a little bit of endosteal, very minimal endosteal scalloping, this fits into an enchondroma slash ACT, and we did not even biopsy this lesion because there's no point doing it. So BACTIP is the NHS UK, this algorithm to manage a central cartilage tumor based on size, less than or greater than 4 centimeters. And then based on what you see, you kind of decide what to do. Again, this is great for a central system like the NHS, where once the referral comes to a specialist center, you're able to do all of this. You're able to say that, okay, we will not do an MR, or we will do an MR, and then you send reminders, and all of that then happens. In the Indian setting, that's not necessarily true, because the patient's wishes also become important, and if everything is indeterminate, you might still end up doing a biopsy if not required. For example, 39-year-old has a cartilage tumor. By all respects, this is a benign cartilage tumor. The SUV is also less than 2, but the patient had pain, and the patient says, I want to know what this is. Very intelligent, and it didn't matter how much we said, you don't need a biopsy. So we biopsied, and it's a bland enchondroma ACT. Proximal humerus lesion, while this is again benign, less than 4 centimeters, no cortical break, no extraosseous extension, the first MR report said could be chondrosarcoma. And once that was in the patient's head, they wanted a biopsy confirmation. And this also turned out to be enchondroma ACT. And the same thing happened with this patient. Though here, I pushed for the biopsy, because though this looks like a cartilage tumor here, it doesn't show your classic T2 bright appearance. And so my point was, if it's not classic, and there is this little thinning of the bone here, and you see this little bit of endosteal scalloping, it is just worthwhile biopsying this, because there is no reason why this should be T2 dark here rather than bright. And it turned out to be enchondroma ACT anyway. But now here you have a patient who's got endosteal scalloping and cortical tunneling. Longish lesion, painful. MR shows cortical tunneling here. That's a sign of an aggressive lesion, and this was a grade 2 chondrosarcoma. Here you have extraosseous spread, cortical break, so automatically becomes high grade. Though on the biopsy that I did, it showed low grade, but I said if you have a cortical break, it becomes high grade. The moment we'd established in the 37-year-old that this was a cartilage tumor on histology, there was no question of treating it as low grade, because there's no way that a low grade enchondroma will have a cortical break and extraosseous extension. Then these are obvious chondrosarcomas, long segment, 10 centimeter, cortical break, extraosseous extension, and it's cartilage, right? Lobulated, T2 bright, etc. But the dichotomy in our practices is, at specialist levels, when you have a bunch of experts, then there's so much discussion on enchondroma, ACT grade 1 chondrosarcoma. But in the real world, you still have these kind of rubbishes happening. So long segment lesion, 52-year-old, and I did this as case 39 as a whoops lesion, and the MR was reported as osteomyelitis. So the general orthopedic surgeon didn't question the report, curated it, and there was no histopath, or perhaps it was intentionally misplaced. This nail was put inside. This was at presentation. 7 months later, this is what the patient has. Classic cartilage tumor. It was always a chondrosarcoma. Cortical break, extraosseous extension, no marrow edema, right? Absence of marrow edema rules out osteomyelitis. I think we just need to keep remembering that again and again and again and again, right? That's extremely important. The presence of marrow edema doesn't confirm osteomyelitis because you can get marrow edema with a lot of other conditions, but absence of marrow edema almost always rules out osteomyelitis. Here's another patient, 65-year-old, again, somebody called it osteomyelitis. To their, this, whatever, there is a little bit of marrow edema on the stir, but not on T1. That should have been um, a flag, but this is a greater than 10 centimeter lesion. I mean, it is cartilage. It should have been called chondrosarcoma. Luckily, they didn't go in and curate it. All they did was wait a little bit for 3 months, give antibiotics and wait, which was okay because no harm done. Did the biopsy and it turned out to be chondrosarcoma. And I would still say this, that for all of these focal bone lesions that are not your classic osteoblastoma, chondroblastoma, you should just send these to orthopedic oncosurgeon. They should not be managed by general orthopedic surgeons. Thank you so much for listening to me, and I hope I've clarified a few things as far as central cartilage tumors are concerned.